All right, guys, welcome back. The anti-infective chapters that we're going over tend to be some really big chunks of information. I try to kind of split them up into kind of little learning size bits for you. So hopefully you'll enjoy that. Let's get started with our learning outcomes. I'll let you guys read through those on your time. More learning outcomes. Final set of learning outcomes. Now to the reason why we're here today. Today we're here to talk about tuberculosis. So tuberculosis is one of those bacteria that's actually pretty interesting. It's an encapsulated bacteria, and so what it does is it grows really, really slowly, and it grows like layers and layers and layers around itself, so it kind of has like a hard candy outer shell, for lack of a better term. Tuberculosis has actually been around since the time of Christ. Whenever we dig up mummies in Egypt, people would talk about how they would years later would die from the curse of the mummy. Kind of find out it wasn't the curse of the mummy, it was tuberculosis. Very slow growing organism, and whenever things are really slow, it's actually much harder to catch and to get to the inner core of it than it is if something is really fast growing. So like our medications that we give for infections like strep or staph, those tend to be rapidly dividing and go really, really fast. Well, so like penicillin and cephalosporins work really well on those because those cells are dividing fast. When things divide really slowly, it can be very hard to penetrate that hard outer shell of that disease. And so because of that, it's a much harder to treat. So tuberculosis is definitely hard to treat, and you will definitely see it in your lifetime somewhere in your practice. When we talk about tuberculosis, I think probably the most common way, the common form that we see tuberculosis is it's in the lungs. However, tuberculosis is a drug that, hey, it has a passport, it'll travel to anywhere. So it can be in a lot of different spaces and places that you probably wouldn't think about. We definitely think about tuberculosis when we think about people who have recently moved from a third world country into the United States, low income groups. Anytime you have people who are living in massive groups together, jails, nursing homes, prisons, concentration camps, wherever they're living at, those patients would get worried about tuberculosis spreading. And of course, our patients, us ourselves, as healthcare workers, are more likely to develop tuberculosis or be exposed to it because we're constantly in contact with it. I will kind of give you a little bit of a reassurance that to actually obtain tuberculosis, it takes work, okay? I will say that most healthcare organizations have gone to actually monitoring their employees on a fairly regular basis. So if you do contract tuberculosis, you'll be able to see what's going on, and they'll give you some instructions on what to do. So there are a couple of different types of tuberculosis, and what I mean by types is that you usually have like an active state and a latent state. So with the latent people, these are the ones that don't have symptoms, they really don't have any symptoms, they don't feel sick at all, versus the active patients. When those active patients present to in front of a healthcare personnel, you are going to be able to be like, something's wrong, I don't know what it is, but we're going to need to figure it out, because they're going to look sick. One of the key signs here is if they're coughing up blood, that's probably tuberculosis. Weight loss, no appetites, and sweating at night, those are probably the key cardinal signs of tuberculosis in a population, especially the sweating at night. If someone tells me they're sweating at night, I want to run a tuberculosis skin test on them. Oh, if you have a latent disease, the latent disease can't spread it to other people. They typically will have a positive skin test or a positive TB test, but they won't necessarily have it any clinical manifestations of it. Sometimes we will consider treatment for patients who are newly diagnosed with latent TB. Sometimes they don't. With active TB, we're always going to be forcing this patient to get tuberculosis or to get treatment for it, because if they don't, then their risk of passing it on to the next person, the next person, the next person is pretty high. Anytime that we have anyone in a household who's living with someone with active tuberculosis, what we want to do is we want to make sure that those patients are receiving chemoprophylaxis for tuberculosis. So we'll go into the home, skin test everyone. If they don't show up positive, then we'll do like a kinder, gentler TB treatment than what we do to someone who's got active disease. So how do we diagnose tuberculosis? So one, you have to have symptoms that would make you think, well, maybe this patient's got tuberculosis. So coughing up blood, night sweats, loss of weight without intentionally doing so, those would all kind of lead me to look down the path to see whether or not this patient has tuberculosis. We would need a positive skin test and a positive interferon gold examination, which is a blood test. And then maybe we take a chest x-ray on them to see what their chest x-ray looks like. And then finally, what we would do is to help confirm it is we'd have the patient collect sputum for 3 mornings in a row, because that's when we get the most amount of bugs in the sputum itself, is first thing in the morning. And then we would send that off to detect if it has any acid-fast bacillus in it. That's the organism that we're looking for. If we get a positive sputum culture with a positive skin test, we tell the patient they have tuberculosis, and we begin therapeutically treating them with a tuberculosis elimination plan. By no means, as a nurse, are you ever going to have to be able to read a chest x-ray. But, you know, sometimes when we talk about these things, we're like, oh, nodules on the chest x-ray. Well, then you don't know what that means. So I just wanted to show you what it looks like here on the screen. And basically, the nodule that we're looking at here is in the upper right-hand corner. You see how it's encapsulated? It's got like a wall around it. There's also another one right over here in the upper left-hand corner. Those would be the encapsulated nodules that they would be looking for on the x-ray. So with tuberculosis, we have 4 different types of drug treatments. Typically, whenever we are prescribing these medications for patients, we're going to start off with plan number A, and then we're going to transfer to plan number B. It can take about 3 weeks to get the AFB testing back. It is a send-out lab for us in the Brazos Valley, meaning that we actually don't test the lab results here. They go to another lab in another state. Most of the time, they either go to the NIH or they go to the CDC, which are both located on the East Coast. So these are the drugs that we would use to treat both the latent form and the active form of the disease. Let's talk about each different type of a treatment as we go through. So for the first treatment, this is someone who's got active tuberculosis. For the first 2 months, or until we get the sputum results back, they're most likely going to be on 4 different medications. The isoniazid, the rifampin, the pyrazinamide, and then the ethambutol. Yeah, ethambutol. There is no easy way to say that, people. So what we do is we send the sputum results off. We'll start them on all 4, and then usually once we get those sputum results back, most of the time, if we're not dealing with a drug-resistant tuberculosis, we'll just keep them on the top 3, the isoniazid, the rifampin, and the pyrazinamide, okay? So we do that a total for 2 months. Then, after that, then we will do a 4-month regimen and have them come in 2 to 3 times per week, and we'll give them isoniazid and rifampin. It is very important with these patients that when they're taking this medication that we have strict medication adherence. If we do not have strict medication adherence, they will develop, they have the potential of developing tuberculosis resistant to TB, and that could be really harmful for our community. It is in our best interest as a community that we invest time, money, and resources into these people and get them cured of tuberculosis, because we don't want them spreading the TB throughout our community, and especially not drug-resistant tuberculosis. This is the isoniazid, just a quick little snapshot about it. Again, the dosage is going to be different for our active versus our latent. One of the nasty side effects that happens with isoniazid is that patients will develop this peripheral neuropathy. The good news is not a big deal, because we know that this is going to do this. And so because of that, the first thing we want them to do is we want them to take a vitamin B6 supplement. We want them to take that because it will prevent the peripheral neuropathies from ever developing. So very important that we prescribe that whenever you see a patient who's on isoniazid, that it's followed up with that vitamin B6 prescription. I kind of wish that chemists would figure out how to like mush these two together. That way it's just part of the package, but unfortunately it hasn't happened that way. Again, we do have a slight warning here about aluminum products containing aluminum. No more than 2 hours before or 2 hours after this medication, because we want to make sure that we don't have any aluminum products coming in there and like, oh, isoniazid, it's been so long since I've seen you, and like hugs onto it and never lets it go. Awkward hug, never lets it go. So again, we want to make sure that we separate these substances by at least 2 hours before or 2 hours after. The other weird thing with isoniazid is that we want the patient to decrease their tyramine consumption. And I have a slide next that'll show you what tyramine foods are high in tyramine. So these foods, here's a little list. If I was going to cut stuff out and put in a notebook for myself or something that I'm going to need later, this is one of those things. These are the types of foods that frequently have high tyramine. I will tell you that in the Brazos County, we have a large number of Hispanic patients who have tuberculosis, and so because of that, you can see here on this list that there's avocados, meat extracts, those are part of that culture's normal diet. So it can be kind of a complicated process to help them to understand that we really don't want them to eat a lot of these types of foods. We need them to choose other food choices. Otherwise, their medications aren't going to work, and their tuberculosis is going to could potentially mutate into a drug-resistant form. So this is one of those lists that I would keep on to, not only for our tuberculosis drugs, but also whenever we start talking about antipsychotic medications, because some of those medicines are highly affected by a tyramine-rich diet as well. Here's our fun little slide all about isoniazid. The other thing is too, is we don't want our patients to consume a lot of alcohol when they're taking isoniazid. Isoniazid tends to be pretty tough on the liver as it is. And so we bring that patient back in frequently to look at those liver enzymes. And if I was wanting to evaluate someone's liver, I would look at what two lab values. I heard AST and ALT. Very good, very good. Again, there is a couple of people here that does not play well with isoniazid. Phenatonin and carbenzamine don't play well with isoniazid. They mess with the concentrations of the drug in the system. So I'll tell you that I've started myself a little list over here, and it says that meds that don't play well with others: phenatonin, carbenzapine, warfarin, cyclosporin. So as we're out in the community and we're seeing these patients in their homes or at the hospital, wherever we may be, we need to be looking for these guys and think to ourselves, if our patient's on any one of those, man, they could really have some medication adverse reactions just because of the medicines that they're on. So be thinking about that. Maybe you want to start yourself a little list. So pyridoxine, also known as vitamin B6. Remember, isoniazid has a girlfriend. Her name is peroxidine, and she's vitamin B6. And isoniazid don't go anywhere without his girlfriend peroxidine, because they have to go together. Otherwise, isoniazid will cause peripheral neuropathies. Your patient's medication compliance will go down. We've got to keep this from happening. No numbness in the fingers or the toes. We don't want our patients to be miserable. We want them to be med compliant. Rifampin. So a little fun fact about rifampin is that it doesn't matter if it's your tears, your sweat, your TT, it's going to turn everything orange, okay? So if you have a patient who's wearing contact lenses, then they may tell you that all of a sudden they kind of have like this yellow to orange hue over everything, because rifampin is known to change the color of your secretions. So very important that you tell patients this before they start to take it. It'll stain their contacts, like the insides of their shirt will kind of like start to stain out a little bit orangey yellow. If they go tinkle or have any kind of vaginal discharge, it might be a little discolored, a little rust colored. So important that you teach these patients about this reddish orange hue. Otherwise, they're going to be freaking out when things begin to change color. Presenamide, this is another one of those medications that we use in conjunction with our isoniazid. It's our second medication, or after the rifampin. Again, medications can jack with the liver. So with these patients, we're going to be bringing them back in frequently for an AST and an ALT. The other thing that this one does is that it can increase your uric acid levels. Increase in uric acid levels leads to this gout attack. So you hear about people who have the King's disease, or they have swollen great toes. This could all be related. This could be related to a uric acid level increase. The other thing that pyrizinamide does is that it can also cause hemolytic anemia. So again, frequent blood testing is going to be required, close monitoring of these patients. As a nurse, I'd be calm saying, okay, when you're shaving in the morning and you nick yourself, how long does it take for it to stop bleeding? You got any weird bruising going on? Let me see it. Okay, I want to be looking for these signs and symptoms of anemia. I want to be asking them, so tell me about your bowel movements. Are they really black and tarry? Are they dark? Whenever you vomit, are you coming up? What about whenever you're coughing? Are you coughing up blood? Again, thinking about these things about this patient and how they may be becoming anemic. Ethambutol, this is our last medication that we would give for patients. Again, it comes in a 4-drug combo. Most likely going to give all 4 right at first, but then once that sputum culture comes back, we can knock them back by 1, and that's the first 2 months. We're really going to pow, going to whack this thing in the face for the first 2 months. And then after that, we get to kind of back off and just give the isoniazid and the rifampin for the remaining 4 months. This medication can cause some changes in the vision, and so we want to know for certain, like whenever this patient comes in, it's a great idea to start with an eye exam and then ask them on a weekly basis. So tell me, how's your vision? Maybe even assessing their vision. So you take one of those little fun cards, you know, with all the letters on it, and you hold it out 20 inches from your face, and then you read off of it, or put the chart on the wall, have the patient step back 20 feet, have them read the chart off the wall. FYI, in the hospital, if you look at the ceiling tiles, each ceiling tile is typically 2 foot. So you can say 2, 4, 6, and you just step back that many ceiling tiles, and that gives you your 20 foot. Okay, yeah, things that have saved my life over the years. Again, looking at the liver studies, which is your, I heard AST, and ALT, and our renal studies, which is our BUN and creatinine. Good. So let's talk about those patients who maybe they live with someone who's got active TB. Again, this is the patient who we want to make sure is if they're immunocompromised, if they have anyone living in their home that would be more susceptible to get TB, we want to know about this. HIV, cancer, autoimmune disease. These patients may just need 9 months of isoniazid therapy, or just kind of a 2 months with a quick combo regimen. They may give them 3 drugs, they may give them 2 drugs. It really kind of depends on the patient themselves. So again, if we have a patient who have tuberculosis, typically these patients are not treated inpatient. They are treated on an outpatient basis. We would see them most frequently at our health departments. And again, as a nurse working in a facility, nursing home, jail, common living facilities, if you're working down along the border in some of the camps, need to be thinking about tuberculosis. We want these patients to come in for follow-up. We don't want to lose them for follow-up. We want these patients to be very compliant. There have been cases in the past where patients have not been compliant with their medication regimen or their plans. Some of them have actually made national news. And what we do is we'll actually put them in jail and give them their medications until to a certain point. So therapy can last anywhere between 2 to 24 months. We will do more acid-fast bacillus testing. That's where they have them spit in the cup and test it. We will repeat that process every so often to see kind of where we're at. Fungus. Ooh, there's a fungus among us. So typically, first off, fungus is not really all that bad of a guy. I mean, he does have a purpose. His job is to help recycle the world. Okay, they help to compose the dead things that were in our environment. Otherwise, we just have a bunch of dead stuff laying around all the time. There's basically 2 ways that we get fungus. It's either a handling of contaminated soil or an overgrowth of our own normal flora. I will tell you that typically patients who are not immunocompromised typically don't get a lot of fungus, but when we do get fungus, it can be make us pretty miserable. So there's 2 different types of fungus among us. We have community acquired and we have nosocomial. So like the sporochitosis here, that's where you would get it from like roses. The blastomycosis comes from like decaying wood products. Histoplasmosis is from bat and bird droppings and cat droppings. Coccidiomosis comes from the soil. Candidus, you normally have candidus that lives in your vagina anyways. It's just under control. But when it gets crazy down there, it gets a little and it can overdo it. Aspergillus comes from dead leaves, stored grain, compost piles. Think about like decaying vegetation. Cryptococcus is found in the soil, and then mycocosis is actually found in the soil and in decaying vegetation. So I'm thinking about all of my little old people who love to garden and they love to do their own composting, and how they go out in the spring and what do? They clear out all their flower beds. Well, there's a whole bunch of that dead, decaying vegetation. That's when those spores are most likely going to go out into the air, and they're either going to put them into their lungs or get them on their skin, those sort of things. If their immune system's intact, we're good. If their immune system's not intact, like in the case of a patient who's got cancer or a patient who's got HIV, then that fungus can become not only superficial, but it may become systemic. When we talk about our systemic ones, our superficial ones, these are ones that you probably have heard about before: jock itch, yeast, athlete's foot, ringworm. The systemic ones are a lot more scary because whenever they get in and they do what they do on the inside, it can kind of like overwhelm your body's defenses really, really quickly and can actually be fatal for our patients. Here's our drug categories that we'll most likely be talking about as we go through. A lot of the superficial ones are over the counter. We can get clotrimazole, miconazole, and even nystatin. Wait, I said nystatin. I don't know if you can get nystatin over the counter. I know you can get clotrimazole and miconazole, but the nystatin is one that we see frequently when we're in the hospital. So a lot of these are superficial medications that you put right on the area that's been affected. And then we have some systemic ones that are nasty. And what I mean by nasty is not that they're like, gross, like, ugh, that's gross. It's more like they have some really wicked side effects. Amphotericin B is really notorious. It has a bad reputation. I've given amphotericin B one time in my nursing career in 20 years. And before I gave it, I had the drug book out and I'm reading through everything. It's a whole chapter on amphotericin B before I gave it because it terrified me because I don't really give it all that often. Here's some brief photos of some different types of fungal infections that you can see. The first class of medications that we talk about are the azoles. And basically what the azoles do is they help to pick apart the fungal cell membrane so that way they can get inside and actually break down the membrane and make the fungus go away. Nystatin is probably the most topical, fun one that we'll see in the hospital. We see a lot of nystatin. We can have an oral nystatin for the mouth if we've got thrush. We can have nystatin powder that you sprinkle on like a baby shaker. They have nystatin cream that you can rub on. It comes a whole bunch of different ways. For thrush, when you ever think a patient has thrush, if you go in and you scrape it off and it starts to bleed, most often that's thrush in the mouth. Babies can get it, elderly people get it, people who are immunocompromised, they can get it, and it can be so horrible and so debilitating for those patients. One of the things that they'll do is they'll have them do what's called a swish and swallow. And nystatin comes as like a yellow liquid powder, and you shake it up, not a liquid powder, it's a suspension. Shake it up really good, and then you put a teaspoon or a 1 ml in each cheek, and you have them swish it all around. If it's the thrush is down their throat, we have them swallow. If it's just in their mouth, we'll have them spit it out. Clotrimazole, also known as Lotrimin, another one of those great medications. We can buy it over the counter. It does great for vaginal candidias, athlete's foot, athlete's jock itch. All those can all be treated with clotrimazole. Amphotericin B, it's the bad boy. We'll just say the B is for bad boy. It's very toxic. It's given IV only, and it requires that you're watching their eyes and nose really closely because it can really mess up the kidneys. So one of the crazy things about amphotericin B is that you cannot flush the line with it after you've given it. Normally you give an IV, you go and you get some normal saline and you flush after. Amphotericin B, you do not flush with normal saline after. In fact, what you do flush with is D5W. Okay, you got to flush the line with D5W before and after you give amphotericin B. That's one of the only medicines I've ever found to be that way. So just be thinking about that. Also too, when this one comes from the pharmacy, the last time I gave it, I was like, really? I'm going to put that in there? It looked like orange juice. Okay, it was crazy. Protozoal infections. Guys, these are nasty. Protozoal infections, one of the things that you need to know about that is typically the way that protozoans work is that they have this like varied life cycle, like a beginning, a middle, and an end kind of a life cycle. And what we need to do is our drug therapy is actually kind of tailored to hit at certain parts of the life cycle, like different medications would be used at different parts. So because of that, protozoan infections can be kind of complicated to manage. But as a nurse, what your responsibility would be is to recognize that there's an infection going on and then to give those medications.
Yeah.
We don't typically see a lot of malaria here in the United States, but however, our borders are so open and people just come and go and they're from so many different places. So asking patients, well, where have you been recently? Have you traveled outside the United States in the last 30 days? So I've been to South America a couple of times to do some mission field work. And while I was down there, when I came back for like, they're like, okay, have you been outside the United States in the last 90 days? And I'm like, yes, I've been out. I've been to like, I was in Mozambique. And they're like, after that, everyone treated me like I had the plague. They're like, oh, you should go sit by yourself. And I got handed masks everywhere I went if I had to do anything healthcare wise. I'm like, guys, it's good. I wasn't in a bad place. It was just Mozambique. But anyways, so we always ask patients about where they have traveled to. With the disease process of malaria, these patients have really, really bad flu-like symptoms. They get fevers, they get chills. And the problem is that because they're protozoan in nature, is that you have life cycles. So whenever the life cycle of that protozoan gets really, really high, that's when they have the symptoms. And then we kill them off and they die. Well, we might not have gotten all of them the first time that we gave them the medications. So then they may have a relapse of that same disease process. So with malaria especially, it's really important that we complete all the medications, and actually our best treatment for malaria is to actually never get it at all. So for malaria, like I said, prevention is our absolute best key stake. For those of us who are Americans who are going overseas, taking prophylaxis medication helps to prevent you from ever getting malaria to begin with. But for our patients who are present in those states where they don't have the medications, we do have treatments for them as well. So the prototype here, what we like everyone to take whenever they go over there, especially into sub-Saharan Africa, whenever malaria season's going on, is we want you to take the chloroquine. What we find is that there's some areas that are chloroquine resistant, and so we have to use some other therapies in order to protect the patient from the development of malaria. This drug does have a really long half-life, which is great if you're going to be there for a while, but again, do need to know about that. Here's the side effects of the chloroquine. Want to make sure that we're watching out for their vision. Bleaching of the scalp and body hair. It can be a real problem, especially where there are a lot of our native Africans. EKG changes and hypotension. The other thing that we can give for patients whenever they're going overseas and for anti-malaria is you can actually give them just doxycycline, and they just take it for a week. The day they leave America, and then they take it for 6 weeks after they return home. Non-malarial protozoan infections, here's a whole big huge list of them. Basically what it comes down to is when you go to a third world country, you don't drink the water, okay? You drink bottled water that's been processed, or food that's been processed appropriately. With a lot of these medications, whenever you get these type of non-malarial type things, the treatment is metronidazole. With these medications, the most important thing to remember with metronidazole is absolutely no alcohol consumption, because you will get sick as a dog. Anti-health drugs, I'm just going to warn you, the next slide's kind of gross, so if you have any small children, you may want to ask them to exit the room. What you're going to see here on this first slide over here on the front, and those little white things coming out, those are pinworms. And then this is tapeworms. So the patient took the medication, everything died, and then poof, everything expelled at one time. It's just nasty. It's nasty. With these anti-health drugs, the great news is that they work really, really well. They can cause some GI upset, some drowsiness, but again, one of the most important things about these sorts of diseases is good hygiene practices. So wash your hands, wash your hands, wash your hands. eat food that has been prepared appropriately. So what are the most common drugs prescribed for TB? Here's just a couple of slides of questions to kind of help get you prepped for your upcoming exam, things that you should kind of take away from this review series as you go through. So take some time, take your book, take your PowerPoints, and kind of go through and answer all these questions for yourself. All right, just a brief little snapshot here of the mighty world that we live in. And as you can see, there's not a whole ton of cases in the United States. This is a map that shows the population density of tuberculosis from around the world. It's kind of interesting, the number of places that have tuberculosis where it's pretty endemic versus those that doesn't have any at all. So kind of a neat little map to look at. All right, guys, that is everything about TB, protozoans, and helminths and fungus. I hope you've enjoyed it, and we'll talk to you soon.